So good afternoon, everyone. I would like to thank the organizing committee and especially Professor El Kadur for this kind invitation. I've been asked to talk about the complications associated with the frontal lobe surgery. I have nothing to disclose. Now, we know that the frontal lobe is the largest area of the brain, and there are a lot of pathologies associated with frontal lobes, such as trauma, tumors, vascular pathologies, developmental, and of course, epilepsy cases. And there are different ways to approach the frontal lobe lesions. So we can do it either transcranially or transsphenoidally, and of course, we can use combined approaches as well. For many decades, we used to believe that frontal lobe was a silent area, but is this the case? Now we know that there is increasing evidence in the pertinent literature showing that frontal lobe lesions are associated with problems in cognition and in behavior. And these problems actually affect negatively our everyday living and our social and academic achievements, and of course, the quality of life. So frontal lobe is associated with the executive functions. Executive functions allow our autonomy, and executive function seems to be responsible for learning and ongoing cognitive development. And it has been found in studies based on frontal lobe epilepsy with children with frontal lobe epilepsy, that these children are at greater risk regarding school problems. And telling about school problems, we mean attention, memory, and behavioral problems, as well as social achievement problems. And we also know that frontal lobe is the center that controls our emotions. So we could say that the frontal lobe is the home of our personality. And we as surgeons know that when we perform surgeries, complications might happen. So most of the data available is coming from frontal lobe epilepsy surgery patients. And now we know that 38% of these patients will develop personality and behavior problems. And almost 10 of them might be severe. 13% will develop psychiatric disorders, including depression and anxiety in most of these cases. 5% will develop motor complications, and 2% in cases that the lesion is located in the dominant hemisphere will develop aphasia. And we also know that when treating by surgery children suffering frontal lobe epilepsy, then these children might postoperatively develop difficulties in naming, working memory, and visuospatial attention. And it has been found that in almost half of these cases, a decline of more than points in IQ might happen, hopefully without any mental impairment. And the question arises at this point is, what is the price of cure? Most recently published data have shown that in these cases, the individual deterioration might be observed in a lower percentage. So Ramadani have reported that this individual deterioration was observed in only 16% of the children, all of them suffering focal cortical dysplasia. And it has been found that right frontal lobe might be the origin of obsessions. So obsessions might happen and develop after frontal lobe surgery. And of course, frontal lobe surgery is associated with the orbital compartment syndrome, which might be rare, but it's really severe, and with transient hemispatial neglect. A common group of patients with lesions involving frontal lobe is that of olfactory groove meningiomas patients. And studies on these patients have shown that resection of olfactory groove meningiomas is associated with complete anosmia in 23% of the cases when treated transcranially, and visual deficits are not happening, but this is most even more higher when these patients are treated endoscopically. And of course, CSF leaks and meningitis might happen, which are more commonly in patients treated endoscopically compared to the transcranial ones. Other complications associated with the resection of olfactory groove meningiomas are stroke, hydrocephalus, seizures, infection, and also death. And of course, these associations most commonly happen in patients undergoing transcranial surgery. In general, other complications associated with frontal lobe surgery might be wound infections, subdural hematomas, infection or hematomas within the resection cavity, cerebral edema, pseudomeningocele, status epilepticus, vascular injuries, and of course medical morbidities including infections and deep vein thrombosis or pulmonary embolism. At this point, I would like to draw your attention and mention the role of the SMA in the development of new deficit after frontal lobe surgery. We all know that SMA is located in the medial aspect of the superior frontal gyrus. And we know that surgeries involving SMA are associated with the development of motor deficits and, of course, speech disorders when these lesions are located in the dominant hemisphere. Of course, in most of the cases, these complications are transient, but there are cases in which these complications might be permanent. And now we know that the occurrence of postoperative new deficit is associated with the resection of the SMA activation, but it is not associated with the volume of the surgical resection. And for this reason, we need to know if there are risk factors that might be responsible for the development of this new deficit following SMA resection. And in the literature, it has been reported that the only factor associated with the development of new deficit is that of the resection of the cingulate gyrus. Of course, we also know from the literature, especially from studies in glioma patients, that the resection of cingulate gyrus can be performed with minimal and predictable long-term morbidity, which is less than 5%. So is the resection of the cingulate gyrus the only explanation for the development of new deficit after frontal lobe surgery? Of course not. Other predisposing factors are the size of the resection and, of course, the size of the surgically removed lesions as well. So I would like to sum up and emphasize that it's really important to develop strategies in order to avoid these complications. First of all, we need to respect the eloquent area. We used to believe that frontal lobe was a silent area. Now we know that it is not. A lot of complications and a lot of problems might happen after the resection of frontal lobe. We need to understand the anatomy and the function of the white matter. We need to preserve the frontal horn, to study the cerebrovascular anatomy of the area, and of course be familiar and use modern techniques, resection techniques, such as the subpial resection, because in this case we will be able to respect and protect the surrounding vital structures, and of course will be able to avoid and mitigate postoperative seizures. And thank you very much for your attention.